Okay, so can I start? Okay, talk of the merit nursing webinar series. The topic of this talk, of course, is vasoactive agents and nutrition in the critically ill patient. We are going to talk about, first initially, we are going to talk about the questions from the last session. The moderators for this session are going to be myself and Dr. Jafar. And of course, the presenters are going to be Mehak Amir and Shabana. Next slide, please. So the questions from the last webinar, the first one was query use of accessory muscles. Now, sometimes when we are during your active breathing, there are certain sets of muscles which can help with breathing, but they don't normally do so. And when you start working harder to breathe, these muscles start getting used. And those muscles which are only used when somebody is breathing hard are called the accessory muscles of breathing. Some of these are the intercostals and so on and so forth. So that's the answer to that. What is VQ mismatch? Now, the way, okay, imagine two waterways where two fluids are running side by side. One of these, imagine, is oxygen and the other one is blood. So what happens is that whenever oxygen goes to any particular part of the lung, the blood carries it away to the rest of the body. But as the blood is being pumped against the force of gravity, what you find is that the further away the blood is from the heart, the slower it's, or the less it's being going through that particular organ as far as the lungs are concerned. So the upper part of the lungs, which are highest away from gravity and where the heart has to do the pumping, you realize the worst perfusion.
Mohsin?
Whereas the bottom part of the lung has got the best perfusion simply because it's lower than the heart itself. Now, the idea about why we call it a VQ mismatch is blood is perfusing the bases of the lungs well. Jafar, would you mind answering the question if I'm breaking up?
Yes. Dr. Jafar, can you, are you answering or should you want me to explain?
Go ahead.
Okay, I'm trying to bring the slide back up. Just a second. So what Dr. Mohsin was trying to say is that, you know, he explained to a point where, you know, you have the alveolus, which is the air sac, and then you have the blood vessels. And I also could not hear how far he went, so I'm going to continue my way. And basically what happens is normally there are areas of the lung that have almost equal amount of air and equal amount of perfusion. However, and there are certain areas of the lung, even in the normal state, where the ventilation and perfusion is not equal. For example, the ventilation is highest in the upper part of the lung, and the perfusion is highest in the lower part of the lung. So there's a certain amount of normal VQ mismatch. V stands for ventilation, Q stands for perfusion. So yeah, can everybody else mute themselves, please? Yeah. Yeah. So when that happens, that is what is known as VQ mismatch, which normally is present to a small amount. However, when you have a diseased lung, for example, you have an alveolus or a pneumonia that is filling up the air sacs with fluid or with pus, or if the alveoli have collapsed, like in atelectasis, in situations like ARDS, there is a ventilation issue, and in some cases, the perfusion will continue more than the ventilation. And that is what is known as VQ mismatch. And that is much more exaggerated in disease state. The result of that is that your oxygen level drops because of that. Okay. So the next question is, I hope that answers the question. If not, then please place it in the Q&As again, and we'll try and answer it again. Does assist control ventilation need paralysis and sedation all the time? Absolutely not. What you do need is sedation and analgesia, which is, keeping the patient calm, and you don't want the patient to be in pain. Paralysis is an extreme measure that we do, and we'll talk about paralytics later in the talk today, but paralysis is only done in certain situations when you cannot oxygenate the patient on the ventilator, despite the patient being sedated and despite the patient having no pain. It's only done for short periods of time when you need to improve oxygenation. So answer is no, every patient on a ventilator does not need a paralytic. Every patient on a ventilator does need sedation and pain control. So, and kindly explain the difference between BiPAP and CPAP. And I may let Shabana get into it because she's going to be talking about CPAP on the ventilator in the next slide. Shabana, do you want to take over with the next question and this? Shabana, are you there?
Yes, can you hear me?
Yes, I can hear you. So I'm going to leave this question. When you get to the ventilator slides, you can explain some of that, okay?
Yes, and if you could just run the other question number 4, so at least they know the question.
Absolutely.
Yeah.
That's what I'm getting to. So the question is a long one, so I'm going to just read it. When we discussed ventilator modes, controlled mechanical ventilation and synchronized intermittent mandatory ventilation and spontaneous and CMV. So that is CMV, SIMV, spontaneous, and CMV is further divided into pressure and volume. Either you select volume or pressure, that is correct, but the facilitator related pressure support with spontaneous mode, how? And that's where Shabana comes in, and she can explain this further. Do you want me to go to the next slide, Shabana?
Yes, Dr. Noor.
Yeah. Okay, so go ahead.
Okay, thank you, Dr. Noor. And since we had some queries about the modes of the ventilators that we picked up, that we talked about in our last session, and we had a couple of questions, and we realized it was a pretty much of a rushing talk. So I'm just going to be summarizing you with the ventilator modes. So in the slides that you are looking at, you see there is the child is blowing a balloon. So if you have to imagine the work of respiration, when we are breathing, there are 2 factors which are very, very important. Number 1 is the pressure. Through which pressure, how much pressure you are applying for that balloon to blow. It's from your mouth, right? From your mouth, you put a balloon and you are applying a force as much as you can with the pressure so you can blow the balloon, right? And the second one is volume. Volume, how much, the amount, how far you want to go, how far you want the balloon to inflate. You just inflate like a little balloon, or you want to inflate like a big giant balloon. So pressure and volume are 2 key factors. Almost the same phenomena is going on with our lungs. We inhale from our mouth and we apply a pressure. We give a deep, we give a pressure to go inside our lungs. So we and then amount is going, the air amount is going inside as well, right? So some patients who are not able to do that, either they don't have that much energy because of a disease process, or some of the muscles are not working, any conditions because of which they cannot initiate that pressure through which air could go from their nose or mouth inside the lungs, or they do it, but the pressure is so low that the amount of air which needs to be there in order for the lungs to get perfusion all the way down, the volume is low. Okay, so this is how the ventilator comes out, and it's going to help us either by compensating on pressure or either by volume. Next slide. Next slide, please. Yeah. So if you see this comparison, just we will be focused on one column at a time. Okay. So go on the control. So there are three ways basically through which the ventilator is helping a patient. Either in a control mode. A control mode ventilation, as the name says, control, everything is control. You cannot do anything. Patient cannot participate, just like you have a martial law inside the patient, or you have a clear lockdown inside. You cannot go out, you cannot do anything. Everything has to be done by the ventilator, okay? So here, the ventilator, as it says on trigger, the ventilator is the one who is controlling the breathing function. The patient is all like gone, just like a body, okay? So machine initiates all the breaths and patient cannot. And the target is whatever volume we want the air to enter the body. This is how we set it up. We want like 700 volume, 400 volume, 500. That's how that much pressure will be generated. So that amount of air goes in the body, and then the machine stops and patient exhales spontaneously. Doesn't have to be any pressure on this. Okay, so this is a control mode ventilation. And when the doctors would talk to you about, okay, this patient is on control mode, what are the parameters he will be talking to you? He will be talking to you, okay, patient on CMV mode with a rate of 14. That means machine is generating 14 breaths in a minute in a control mode ventilation with a fixed tidal volume 500 and giving an FiO2 of 80%. That means the oxygen that is going in is 80%. Simple, nothing, no patient mentioned. And this is the mode where you need paralysis, because it's the nature that that body may initiate, breathing. Sometimes you don't have to, you have to tell your body to breathe, breathe, breathe. And sometimes it's an automatic process going on in your body. So your body is, you're breathing, right? You don't have control. So you have to stop that, because if patient is breathing and ventilator will say, no, I will breathe because I have all the control. So there will be a fight between both the ventilator and the patient. In nursing language, we say, oh, patient is fighting with the ventilator. Why? Because patient is trying to breathe and the machine is breathing, because we have set the machine to breathe. So in order for the patient to just go down and do not breathe, get him paralyzed, and here you use paralytic agents. You start using your sedation first, and then you paralyze the patient, and we'll talk more about on that. The second mode is partial mode, like as name indicate, partial means half. Now you are sharing. Now we are making ventilator a friend of the patient. So ventilator is thinking, okay, you can take some breaths as well with me while I'm controlling your ventilation as well. So the partial control means one patient is also participating in the breathing. So what is a trigger? The ventilator and patients both share the breathing function. Now from the lockdown mode, you are in a smart lockdown. That means you can do something at least to initiate the breathing, right? So machine initiates the breath as a set rate, and they just share in between the patient and the ventilator. And what is the target? Patient will get either a fixed volume or a fixed pressure. Okay.
Shabana, may I interrupt for just a second? I think
Sure.
the column is kind of mixed up here, and that may be because an old slide got in. The second partial control is this SIMV, and the third one is the assist control.
Just
So,
go ahead and click everything, then I think you will get the whole box. I think maybe it's an animation issue.
no, it's not an animation issue. I think it's an old slide that got in here, but it's okay. I just don't want them to be confused. We should.
Yeah, so just to let you know, it's a partial control. Always remember either the pressure or the volume you are setting up on the ventilator, and patient is also participating. But remember, if you have, now you will say spontaneous mode. Spontaneous mode is what? The patient is breathing as well. So how you will differentiate between assist control and the spontaneous mode? Remember, in spontaneous, everything is patient. You are just putting up a little bit setting on the ventilator, but the work of ventilation is on the patient. Now here the question is, if we have partial control ventilation, we say assist control or a partial control, mostly we say assist control, which is like the same thing, a volume control or pressure control or SIMV. So what is the difference between volume and pressure control and SIMV? They look almost the same. Yes, they are. But if you are in a assist control ventilation in which the machine is breathing and the patient is breathing, you are providing a set volume or a set pressure. But in SIMV, when the patient is initiating, in patient's breath, when patient is breathing, he does not get the full set volume or full set pressure. He will get a little bit from the set pressure which is in the ventilator. Okay, so again, the assist control is halfway that you work on the ventilation. It's a smart lockdown mechanism in which the patient has the liberty to initiate some breaths, and this is how it looked like a SIMV of 10, tidal volume of 500, and we just give a little bit of PEEP to help alveoli keeps open up so we can have more oxygen going in the alveoli for the gas exchange. Now the spontaneous mode, and as I said, spontaneous mode is all free. This is what's right now. Now we are not in a smart lockdown. We are just free to go, right? But still we have to follow some SOPs. So those SOPs we are following through some of the settings that we have done on the ventilation, like we just put some pressure support, or we can just have some PEEP. So that helps the patient to have more ventilation. Okay, so in a spontaneous mode, you can have either a pressure support ventilation or a CPAP mode. So what's the difference between these two ventilation? In a pressure support ventilation, when the patient breathes in, and whatever pressure you have set on the ventilator, say 15, okay? So in each breath, patient will get a 15 centimeter of pressure support, okay? But in a CPAP mode, yes, there is a pressure, excuse me, there is a pressure, but in CPAP, the pressure remains in the air in the lungs. So your alveoli are kept open. It's just like a PEEP concept, the concept of PEEP, in which you keep your alveoli open. So that pressure that you are keeping in the CPAP mode gonna be there during inspiration, during expiration. But in a pressure support ventilation, when patient is inspiring, when patient is breathing, he will get that much of water pressure in the body, and of course when he's exhaling, there is no pressure. Okay, so I have tried to make it very simplified in a way that control mode or lockdown mode, you cannot do anything, you cannot go out, you are just there locked in your own way, and you have been given some paralytics, so you don't just participate in the breathing. Okay, partial control, in which the machine and the ventilator both are working, but in one category, patient is getting all the fixed volume or all the fixed pressure, but in another category, in SIMB, patient is initiating breathing, but he is not getting the complete pressure and volume that you are setting in the ventilator if patient is breathing. Okay, and those are the additional breaths that he's taking. If we say SIMB of 4 and patient respiratory rate is 14, that means the 4 breaths were from the ventilator and 10 were from the patients. So all the 10 that patient got may not have the set volume of pressure. Okay, he may get a little bit, just like if patient will breathe, he will get less, but if machine is breathing, he will get the whole liberty. Okay, everything. So just, it's a weaning mode. You're just giving the patient an opportunity to, okay, just do something, so we'll see how you're working. If you'll do good, we'll remove the ventilator. Okay, and the spontaneous mode is all patient. Okay, but in that, either you set up a pressure or CPAP. Pressure support, when you're inspiring, taking breaths, you will get a set pressure to keep the airway, to help supplement your pressure, so you can have more air go in and you and you know, help you in breathing. And the CPAP, either you inspire or you expire, that pressure remains in the airway. I hope I tried to make it simplified, but still you have questions, please feel free to put up in the question and answers, and we'll try to make it more simpler and explain in the next session.
I see. Yes. Thank you, Shabana. I'm going to go to the next slide for a second, but
yes.
I just want to tell the participants that they're raising hands. I would like to continue the presentation. And if we have, hopefully we'll have about 10 minutes at the end, and we can take those questions at that time, or please put it in the Q&A and Dr. Jaffer will try to answer it while we are going through. Okay. Thank you.
Okay.
Thanks a lot. I just want to say the difference between CPAP and BiPAP that somebody asked, and I think Shabana may have said that already. But when you have a spontaneous mode with a CPAP, you only set one pressure, like inspiratory and expiratory pressure is the same, and you can have a BiPAP mode on the ventilator or without the ventilator with a non-invasive mask, and there you set two pressures, the inspiratory pressure and the expiratory pressure. So those who are raising hands, please put your questions into the Q&A or please wait till the end. Thank you. I'm going to continue. So
shall I start?
yes, please, Mehak.
So we are moving towards the main drugs which are used at the, in the critical care settings, and we are going to list down some important medication which helps the patient to elevate the blood pressure, their indication, mainly the paralytics, vasopressor, inotropes, its nursing consideration, and as well as we will also illustrate the importance of nutrition.
Excuse me,
In the critically
Mehak, your sound is not clear. Do you have two devices on? Do you have a phone and a computer?
No, I just have a phone.
Okay, all right.
Now it's clear?
Better.
So moving towards the case scenario, as you can see the case scenario, next slide please.
Make sure that you don't have two devices on.
I just have only my mobile phone on. So, looking towards the slide, we have a case scenario that a patient, Mrs. N, have developed acute respiratory syndrome, and Mrs. N is intubated, and it's 24 hours after intubation. No feeding hasn't started yet. And when you see in the cardiac monitor, so you saw alarm that the BP is 75/56 and the MAP is really low, it's below 60. And the physician ordered to start levofloxacin, which is norepinephrine, at 5 mics per minute. And he advised you to titrate and keep the MAP. Your target is to keep the MAP above 65. So, performing the assessment, you notice that Mrs. N is struggling with the ventilator. There's an asymmetry between ventilator and patient, and the respiratory rate is also elevated and oxygen saturation is dropping. So, the physician advised you to sedate Mrs. N. Next slide, please. So, what you think that what is happening and what's going on here? So Mrs. N is hypotensive and she needs vasopressors. Mrs. N needs tube feeding as well. She needs sedation, and still, if still she's not doing well, she may need paralytics. So we'll discuss about sedation and paralytics in later slides. Next slide, please. So
Yeah,
here are the categories.
May
Yes.
I ask you to remove your, because there's a lot of noise. Do you mind? Can you just talk into the phone without the headphone, or you can't do that?
Okay, okay.
Let's try, because I think the mic might be the problem.
Now it's clear?
Much better, yes.
Okay. So here are the categories of the drug which we used in ICUs, that are vasopressors and inotropes. Dr. Noor, just click on that slide so the vasopressor part comes.
Yes, sure. Sorry about that.
No, it's okay. So vasopressors, inotropes, sedatives, analgesics, and paralytic agents. Here are the list of the drugs which we use, and we will discuss in the later slides one by one. So it's norepinephrine, epinephrine. In sedation, we use mostly propofol. Nowadays, Precedex is also a good option. In analgesic, we use opioids, non-opioids. Paralytic agents, we use atraculum and succinylcholine. Next slide, please. Yes, this is a very important slide. It helps us to understand the basic difference between vasopressors and the inotropes. So the vasopressors are the drugs which constrict and target the different receptors in the body, and it helps the vasoconstriction. And inotropes make the heart pump faster and stronger. So the inotrope increases the heart rate and increases the pumping and the contractility of the myocardial muscles. So it increases the heart rate. So here we have drugs which have both the properties. So it's norepinephrine, like levofloxacin, norepinephrine, and epinephrine, and dopamine. they both, three of them act as a vasopressor and an inotropic agents. While vasopressin is only a vasopressor, like it's purely a vasopressor which helps to constrict the blood vessel, and phenylephrine. Other is dobutamine. It is only inotrope, and we will discuss further that why the dobutamine is the last choice, and it has also a side effect. It also causes hypotension, and the basic thing why it causes hypotension we will discuss when we will discuss dobutamine. Next slide, please. So yeah, you need to be very aware when you are running dobutamine. So there is a drop in blood pressure, so you need to be very much careful with that. So we'll discuss why it tends to cause the blood pressure drop. Next slide, please. Yes. So here we'll discuss about the norepinephrine. Norepinephrine is the first choice of drug in the septic shock, but after first you have to resuscitate the patient with the appropriate amount of fluid, and then you have to go for the vasopressor or the inotropic agent. So it's a first choice of drug and usually used in the septic shock. The side effects, as you can see, tachyarrhythmias and peripheral gangrene, because when it is administered peripherally, so it tends to vasoconstrict and the tissue perfusion is decreased. Therefore, the peripheral gangrene chances are much higher, and it is recommended to administer norepinephrine or any other inotropic or vasopressor agent through central line. Next slide, please. Yes, as we discussed that after proper fluid resuscitation, you need to then, if the things are not getting better, then you have to consider norepinephrine as a first choice of drug. Now, vasopressin. Vasopressin is also known as the antidiuretic hormone. This is commonly in the body, in our body, and it auto-regulates the water balance in our body. It is the second choice of drug for the low BP, and it helps in vasoconstriction without increasing heart rate and the contractility, without increasing the heart rate or without increasing the pumping ability. So it is a good drug if the patient has underlying any cause and if the patient has tachycardic issues. So it is a good drug for those patients. Side effects are hyponatremia and bradycardia, so you need to consider the urine output whenever vasopressin is there. So you need to see the urine output very closely, and you need to monitor the patient's sodium level also. And it can be administered in diabetic insipidus, where the water imbalance is there, and visceral hemorrhage, where it will help in squeezing those vessels which are like dilated because of portal hypertension. So it will decrease the chances of hemorrhage.
Mehak, can you please make sure that you are about 12 inches away from your mic? Okay. There is a lot of there is a lot of distortion there. Just keep yourself about 12 inches away from the mic.
Okay. Is it clear now?
Yes, much better. Okay. Thank you.
Now, epinephrine is the last choice of drug, and we will discuss that why it is the last choice of drug. It helps in the arterial vasoconstriction, and in through arterial vasoconstriction, it helps to improve the blood flow to the major organs like kidney, heart, lungs, and it increases the contraction. It has also a bronchodilatory effect as it targets particular receptors, and the knowledge of the things about the receptor you can find it in the resource material. This is the last choice of drug we prefer, and the thing is that it is the choice of the drug in the ACLS protocol when the patient is in cardiac arrest. So you can give IV bolus to that patient, but this drug is the last choice for the infusion purpose because it increases the heart rate and it can worsen the coronary ischemia because it tends to vasoconstrict the arterial and the myocardial arteries. So it can worsen the coronary arteries. So in the risk versus benefit ratio, the risk is the harm is much higher than the benefit. So you always have to consider it, and that is why it is the last choice of drug of vasopressor. Next slide, please. Now the dobutamine. So it is used in the cardiac dysfunction, like cardiogenic shock, severe sepsis, heart failures, and it can drop the blood pressure because it triggers beta receptors in the vessels, and it tends to vasodilate in certain cases as well. So you need to be very much cautious, and you need to keep an eye on the monitor that if dobutamine is there, it's there with the patient and you're running dobutamine infusion to the patient. So you need to be very much cautious that if patient gets hypertensive, you need to stop dobutamine and report it immediately. As all the vasopressors have tachyarrhythmias, so this vasopressor has also tachyarrhythmias and vasodilation, obviously. Next slide, please. Dopamine is a third line agent of vasopressor. It is used to treat the hypertension, and it's third line. There you can see that there is a renal dose and the cardiac dose written. In the old school of thought, and still we are using in our country, that we are using the renal dose, the light, the 0.5 to 3 mics per kg per minute dose. It is considered that the renal dose can improve oliguria, and it helps to improve the tubular function through increasing the blood flow to the renal tubules. But it has no evidence, no research-based evidence of it. So we are not considering it yet in the West. The cardiac dose, yes, above 3 is considered as the cardiac dose for hypertension, for treating hypertension, and it also can cause peripheral gangrene due to decrease in tissue perfusion. Next slide, please. This is a very good slide, a graphical representation or summarization of the side effects of all the vasopressors and inotropes up till we have discussed: noradrenaline, vasopressin, adrenaline, dobutamine, dopamine. So you can see that the risk of side effects of this arrhythmias is much higher in dopamine as compared to all, and in the second one, in the hypotension, dobutamine have much higher incidences of hypotension other than dopamine, because it affects the receptors much more than dopamine. Hyperglycemia, because it affects the cellular enzyme with the insulin absorption. That is why hyperglycemia, and the other side effects are with vasopressin is diabetic insipidus, and it makes MI worsen. With adrenaline, ischemic injury, and when there is an injury in the muscles, obviously the lactate is going to be increased. The GI motility is decreased with the dopamine. The decrease in peristaltic movement is decreased with the dopamine. So you can see the graphical representation of all the vasopressin here. Next slide, please. So here comes a very important part about the nursing consideration. We also should be knowing that what are the major nursing steps when we are administering vasopressin drugs to the patient. So it should be administered through the central venous catheters, CVP or the CVC, or the PICC line in some cases, to reduce the risk of a peripheral gangrene, and it can have the much it should be administered with the infusion pumps, and it should need to be strictly monitored while like the vital signs, especially the BP, the MAP, the target should be above 65 to 70 as your physician advised you. And the infusion must not be stopped suddenly, but it should be titrated and gradually and slowly and gradually it should be tapered off. So every institution have a policy for the tapering of the medication, the vasopressin. So you need to look into it. I have shared a resource in the resource material of how to titrate and how the doses of vasopressin. One thing more, whenever you are administering norepinephrine, I have seen in some hospitals that they are covering the norepinephrine with an aluminum foil as it is a light sensitive drug. So you can do that if your institution policy is there. So you can do that if your pharmacy instructs you. So you can do that. Other thing is that you need to document it. If you are tapering off, you need to document it. You need to write the concentration of the drug. It's a double dosage or it's a single concentrated drug. You need to write so that people in your team could be clear and could get a clear point. And yes, your documentation also saves you. Next slide, please.
Okay, so before we get to the next question, I'm going to ask Shabana to go back to Mrs. N, so you guys can all, let's, wait, okay, so I guess we'll go to the question first and then I'll let Shabana talk about it. Which of the following medications can decrease the blood pressure? So, okay, so we have the answers. Nobody wrote for Levofed, Neosynephrine 14%, dopamine 11%, and 78% of them, Mehak, said that it is dobutamine. So I'm going to come back to you, but let's go back to Mrs. N for just a minute. Shabana, would you mind? Let me.
Yes, so let's go back to Mrs. N, our lovely Mrs. N that we have, she is also, looks like attending the webinar with us because we have been using the Mrs. N since day one with the webinar number 1. But as we said, it's gonna be, these webinars are based on this one case study. So I think it's easy for all of us to relate what we are talking about. So as we see Mrs. N, she is, remember last time she developed acute respiratory distress syndrome, and we were talking about putting her on the ventilators, and that's how the modes of ventilators comes out. And we talk about some of the troubleshooting of the ventilators, and we just discussed that. So now what's happening today when you are in the unit, so after developing acute respiratory distress syndrome, Mrs. N got intubated, we know that. Then after 24-hour post-intubation, there was no tube feeding initiated. When you came in, you found out there is no tube feeding has been initiated on this patient. And while taking report, the cardiac monitor was alarming, and it is alarm. And you saw that she has a blood pressure of 75/56 with the MAP. Mean arterial pressure is less than 60. So you go and you told the physician, hey, Mrs. N, pressure is coming down. So he told you to, okay, start patient on Levofed, okay, at 5 microgram per minute and titrate to keep the MAP of more than 65. And then in the meanwhile, while you're going in and you are doing your assessment, since you just resumed your shift, you saw that Mr. N is struggling with the ventilator. Remember the word struggling? Remember the fighting I just mentioned on control mode? So so she was fighting with the ventilator, and because she's fighting, so her respiratory rate is elevated and the oxygen saturation is dropping because of course patient is just fighting and not enough oxygen is going in the patient's lungs. So the patient asked you to, the doctor asked you to, okay, go ahead and sedate Mrs. N. So put on sedations. So just to relate the first part in which the doctor has ordered you to start the Levofed, which is vasopressors. And as Mehak was mentioning that this medication acts by increasing the vasoconstriction, making the arteries a little bit, squeeze, so the pressure could increase. Okay, and then this is always this medication is the first drug of choice actually when you see a low blood pressure after you have given enough volume to make sure patient is not hypovolemic. Okay, and then as a nursing care, she mentioned about those pressors. Just one thing to correct here, that the dobutamine does not increase the heart rate, so it's not a vasopressor. Vasopressor means vaso, the vessels, pressure means pressure. Okay, so drugs that are affecting on the vessels by constricting to increase the blood pressure are vasopressor. Okay, and dobutamine increase the contractility. Remember, when the heart is pumping, it has to squeeze in a way so the blood from the left ventricle move forward. So it's a pumping action. So dobutamine basically works on the pumping part, so it can squeeze the left ventricle in a way to have more blood going in the system, and you have more pressure in the body. So that's how the dobutamine works. So sometimes, it gets a little dilatory effect on that, and you see the blood pressure gets lower down. So now we will proceed with another set of medications, which Mehak is going to cover. So let's proceed to our poll number 2, right? Question number 2?
Yeah. What I was going to do is, you have described Mrs. N, and both these questions were related to her situation. They've answered the first question. I'm going to go to the second question now before we move on to the sedatives. Okay?
Absolutely. Yeah.
So let's go ahead and do that. So this is question number 2. Go ahead. So one of the major side effects of vasopressors is decrease in GI motility. It causes arrhythmias, it causes ischemia, and it causes hypotension. So we'll give it a little more time. Okay, people are thinking. I can see that. Okay. All right. So the answers we received were: it decreases GI motility 13%, causes arrhythmias 47%, causes ischemia 27%, and causes hypotension 13%. Mehak, you want to take that from here and let them know what the correct answer? Yeah. Can you let them know what the correct answer is and why?
So vasopressin, makes the MI more worsened. So it causes arrhythmias. As we have discussed, that all the vasopressin, the major side effect, it causes arrhythmias. So the major side effect is arrhythmias.
Okay. All right. That is correct. Hello? The correct answer is arrhythmias. It can cause ischemia in some situations, but it's extremely rare, and epinephrine would be the only drug that one would be concerned about. That is why you use epinephrine very carefully. But the major side effect of almost all the vasopressors that we have talked about, except perhaps for vasopressin, is arrhythmias. Okay. So let's go on to the next. We need to stop the poll thing here. Walid, can you remove? Okay, here it is. I removed it. Okay, so let's go on to sedatives.
Now, here comes the sedative part. So you remember the case scenario where Mrs. N was advised, the physician advised you to start sedation as Mrs. N was not breathing properly on a ventilator. So actually, a sedative is a drug which helps to relieve anxiety, agitation, and relieves pain, amnesia, and it reduces the patient ventilator asynchrony, as Shabana discussed in previous slides, that you want the patient to be sedated and the ventilator to get the blood. So you need to sedate the patient. So there comes the sedative parts. And when we are talking about amnesia, there are multiple researches that when the patient is not properly sedated, so there are chances of ICU psychosis and deliriums. So and that is the thing from which patient is struggling with after the course of treatment. So you need to provide an amnesia effect, and you need to reduce the patient ventilator asymptomy. So sedative is an option to use as in ICU settings, and it reduces the respiratory muscle oxygen consumption. You want your respiratory muscles to decrease the oxygen muscle consumption. Sedative is an option. So it requires a continuous patient assessment. We will discuss about SAS and VAS score, sedation agitation score, and Richmond agitation sedation score in the next slide, the latest slide. And the sedation holiday or sedation vacation in layman language, when we are putting off the sedation, for sometimes it calls sedation holiday. So we will talk about it. We will also talk about it in later slides. Next slide, please. Next slide, please. There comes a very common drug, which is propofol. It is a general anesthetic. It is a white lipid emulsion, and when it is administered, the patient must be intubated and ventilated because it causes us a rapid and severe respiratory depression. So the patient need to be sure that the patient is ventilated and properly intubated. You need to monitor BP and oxygen saturation because it causes respiratory depression, and it causes very rapid hypertension. So you need to monitor the BP as well. And when you are discontinuated, if you have discontinuated it abruptly, so it results in rapid awakening and agitation and anxiety. A patient gets severely agitated, and if the patient is agitated severely, so he or she might pull out the ET as well. So you need to be very much focused that how to wean off it. So the proper thing is weaning off this drug, sedative.
Hi, this is Dr.
Hello?
This is Dr. Awais Masood. Thanks, Mohsin. Let me give my some comment on during this discussion. Is it okay, Dr. Zaman and Dr. Kabani? Can I talk a little bit now, or because I think I am interested in giving my comments on vasopressors, and I think we're moving to a different topic right now.
Dr. Awais, that is perfectly fine. We are just, in terms of time, we have about 10 minutes to finish the talk. So did you want to wait till the end, and then would you mind doing that? Or would you like to say something right now?
No, it's okay. Okay, then I'll do my things and I'll come back in 10 minutes. That's
fine. No, you go ahead. You go ahead and give your comments if you'd like to.
Okay, I'll be very brief. So a couple of things. I think the practice, let me introduce myself briefly. So I'm Awais Masood. I'm an intensivist and a nephrologist. Actually, I'm in ICU right now working here in New Jersey, USA. So a couple of things. Practice could be different in different countries. But we don't use dopamine as a pressor. Actually, we don't consider dopamine as a pressor unless a specific indication when patient has bradycardia. Otherwise, in septic shock, particularly, there's no role of dopamine anymore because it causes more arrhythmias, and the vasopressors are, as you said, the Levofit is the first choice, and after that, vasopressin. And a couple of things, vasopressin theoretically can cause this, hyponatremia, but practically it stimulates more V1 receptors. So hyponatremia is a very, theoretically is a side effect, but practically it does not cause that. And same thing about epinephrine. We use epinephrine more now. Actually, we use epinephrine, vasopressin, and then, norepinephrine, vasopressin, and epinephrine, that sequence. We don't use dopamine unless specific situation. And as far as the coronary ischemia is concerned, I think maybe Dr. Jaffer can comment more on that because it does not cause coronary ischemia, it causes peripheral ischemia because we use all the time in post-cardiac surgery patient, epinephrine actually is very commonly used. And we had our experience from post-cardiac surgery patient, after that we use in septic shock. Dr. Jaffer, you have to say anything about that? I mean, like to hear from you. Regarding coronary ischemia caused by epinephrine.
Yeah, I agree with you completely because most of these vasopressors that we use commonly, they do not cause coronary ischemia unless they are very high dose. And most of them, actually, they are coronary vasodilators.
Thank you. And one last thing, that as for these pressure can affect renal perfusion also. And I'm a nephrologist, so I'm always worried about that. So briefly, norepinephrine, it does not cause any decreased perfusion of the kidneys. Vasopressin also does not cause, but as for the phenylephrine, or we don't use much, it does cause that. So, I mean, I can go in detail, but I probably don't have to, but that's my brief comments. And if I'm still here after the end of the discussion, I probably will contribute more to it. So thank you for letting me.
No, not at all, Dr. Masood. We really appreciate your comments, and I'm glad you emphasized the practice in where I am also is the same, that we start with norepinephrine, then vasopressin, and epinephrine is used. I think the coronary ischemia part is definitely something that you do see, but only in patients that have had severe coronary artery disease at some point. But yes, we do use it in septic shock as the third line agent. Dopamine with the renal dose effect. I think the whole idea of the talk was to emphasize that dopamine renal dose is no longer a concept. You know, that's not something that we do. Yes.
Absolutely.
Go ahead. Mehak, I'm going to let you continue.
Thank you all, because it is also increasing my practical knowledge as well. So continuing with the propofol, as we were discussing that you need to start, it's another part that you need to start the tubing after 12 hours, because as it is a lipid emulsion, so the bacterial fermentation or bacterial growth in the tubing after 12 hours is there. So you need to change the tubing after every 12 hours. Next slide, please. Yes. So as you can see that the propofol is a lipid emulsion, looks like milky solution. It decreases in the intracranial pressure. Anticonvulsive properties are there as well. Its onset and offset both are very rapid, and it also causes bronchodilation. But on the other hand, it causes vasodilation. It means the drop in BP, hypertension is there. It increases the cost as the weaning from when we are using propofol at a higher dose. So it's difficult to wean off the patient from the ventilator. So yes, it can increase the cost of the ventilation. It's not an appropriate analgesic, and it has a negative inotropic effect. Like it can decrease the heart rate, and the pumping, and the contractility of the heart. Here comes the propofol infusion syndrome. It is a major side effect of the propofol, and it's very rare, as the risk factors are very low, but there are, yes, the risk factors are there. The increased doses in young and elderly people, or the patient with known liver diseases or the renal diseases, it can cause propofol infusion syndrome to those. So you have to look to the symptoms. Lactic acidosis are there, rhabdomyolysis is there. The reason behind is this, that propofol inhibits certain enzymes at the mitochondrial level. Therefore, due to the inhibition of the enzyme, the increase in the anaerobic transpiration, which ultimately increases the lactic acidosis in the body, and due to this, refractory bradycardia, serious failure is there, hypertriglyceridemia is there. So you need to look to these symptoms so that you can properly identify this syndrome. And if this syndrome, to identify this syndrome, you need to stop infusion, and you need to document it, and you need to identify it to the physician as well, to the team as well, so that they could also know this. The other thing is that with the propofol infusion syndrome, as I thought, that it is very rare, and it always depends on the risk factors and the increased dosage and the amount of the dosage and the length. For how many days we are using propofol infusion. So it really depends on that. Next slide, please. Yes. Now, Precedex, which is also known as the Dexmedetomidine, it is a really new option in the group of sedation for the critical care patient because it causes less or no respiratory depression. That is why we consider Precedex in COVID patients, because we don't want any respiratory depression or the renal issues in these patients. So, and it is easy to wean off those patients who are on Precedex, and it can be used in the non-invasive ventilation as well. But nursing assessment is very much important when we are using Precedex or Propofol or any other sedative. So, frequent nursing assessment is required with Precedex, Propofol, or any other sedative. Next slide, please. Next slide, please. So, as you can see, the side effects like bradycardia, dose-dependent bradycardia, if the doses are higher, then it can cause bradycardia. Hypertension is there, but in some patients, hypertension is also seen, nausea, vomiting, and so you have to give antiemetics with that if nausea is there. The limitations for the use is that the drug is itself is very costly. The infusion is very costly. But on the other hand, if you see the risk versus benefit ratio, so it can it reduces the time of ventilation, it decreases the time of ventilation. So other hand, it is causing the low cost of the ventilator. So when you are seeing both hands, so Precedex is a very good option for us, for COVID patients. Next slide, please. So there's a question that the IV tubing for Propofol should be changed in. These are the options.
Can you see the poll result, or should I read it out to you?
No, I can see that.
Go ahead.
Hello.
Yes, I think you can.
Yes, I can see the poll. Yes, it's correct. The 12 hours. The Propofol infusion should be, the tubing should be changed after every 12 hours, and it should be marked. The tubing and the syringe, infusion syringe, should be marked properly. Yes, you are all correct.
Okay.
Next slide, please. Dr. Noor, now my voice is audible?
Yes, it's better. Let me
it's
get
quite
to
good.
Yes, it's
Okay.
better. Okay, let's see if I can move the slide now. There you go.
Okay.
You have your next
so,
slide.
this is, can I start now?
Yes, please.
Okay. So this is the nursing assessment and the goal of the sedation, that the sedation, you need to monitor the level of sedation. So as in when we are giving vasopressin or inotropic agents to patients, so BP, blood pressures and other vitals are important. Mainly blood pressure and MAP is important, the heart rate is important, and a key factor for us. So here, sedation monitoring is important when we are giving sedative drugs to the patient. So the sedation holiday or sedation vacation is important. Like when this is done by physician or anesthesiologist, they put off the sedation, they taper off the sedation, and they look for the GCS and the level of consciousness of the patient, that how the patient is doing. The next is sedation agitation score and the REST score. Next slide, please. So here comes the sedation score. In most of the hospitals in Pakistan, we use sedation agitation score. As you can see, the ratings are 1 to 7. 1 is unarousable, like no response to the noxious to the painful stimulus, and 7 is very dangerous agitation, like patient is pulling out everything, catheter, ED, and striking at the staff. So it is a very dangerous agitation. 4 is a medial point, like calm and cooperative patient. So your goal should, when the patient is on sedation, your goal should be from 3 to 5. Like patient is anxious or agitated, anxious or physically agitated, but calms to the verbal instruction, but it's not very agitated. Like 6 is very agitated. So your goal is not very much agitation. So your goal should be sedated to anxious. So this is the sedation score. So as you all can see and read the categories, that how we are rating it. The next is rest score. Next slide, please. It's Richmond agitation score. And as you can see that in the between, it's 0, which is alert and calm. And on the downward side, its ratings are -1 to -5, and on the upper side, it's positive, like +1 to +4. So in the minus side, the patient is sedated and the like drowsy, not fully alerted, and from -1 to -3. These all are you all can do with your auditory. You can stimulate the patient auditory sensation. Like you have to call the name of the patient, and with your voice, if the patient awakens, then you have to mark from -1 to -3. Like patient briefly awakens, but the eye opening is less than 10 seconds. So you have to mark -2, which is light sedation. When the patient is unarousable, like he or she doesn't respond to the voice or the painful stimulus, then you have to mark -5. On the upper hand side, like patient is restless, anxious, or apprehensive, agitated. +2 is agitated, like patient is frequent, non-purposeful movements are there, and frequently fights with the ventilator. So your goal should be -2 to +1. Okay, so you don't want the patient to fight with the ventilator. So your sedation score should be, your goal should be from -2 to +1. Next slide, please. Okay. So here comes the benzodiazepines. Benzodiazepines effect lasts 6 to 24 hours, and it can use for the alcoholic patient and the patient with frequent substance abuse. So in nursing, history should be very important. Like you have to take your history component should be very strong when you are taking history of the patient. So there are patients who don't hear in our setting, they will not tell you about they are using alcohols or they are doing substance abuse. It affects the benzodiazepine effects last a long time, and they achieve these effects by decreasing the activity. So it can be given in seizures, like when the patient has history of seizures, as hypnotic, as a sedative, like for the procedural sedation, and for the anxiety in the alcoholic and the patients. In the current practice, benzodiazepines are not much encouraged and are not chosen because it has higher instances of delirium. So it can cause the patient delirium. So the choice is very limited. But yes, we used for the patient who suffer from alcoholism or substance abuse. Next slide, please. So here are the side effects. As I have discussed earlier, that because of the risk of delirium, delirium, we no longer consider benzodiazepines. But yes, in some cases, we also we used benzodiazepine, like midazolam infusion. So this is a pictorial presentation of the side effects, which tells you about all the side effects. As you can see, severe drowsiness, slurred speech, slow heart rate, difficulty in breathing, convulsion. You need to see the EPS, extrapyramidal symptoms as well. Next slide, please. So this is a graph. It is a comparison graph that which drug has the fastest onset and which drug has the slowest onset. So midazolam has the fastest onset than lorazepam, but you can use infusion, midazolam infusion, but can't use diazepam as an infusion. Lorazepam is the slowest onset and a long-acting metabolism. So, and it is not affected by liver disease. But in certain cases, lorazepam infusion is also not used. Midazolam infusion is preferred in the patient, which we have discussed. Next slide, please. So now analgesic. Analgesic is used to control the pain because pain is important to taking care of, as you have to do nursing care. So pain could alter, could inhibit nursing component, your nursing care. So you need to taking care of the pain. So there are two options, opioids and non-opioids. But always you have to control the pain through multimodality. What does multimodality means? Like you have to choose, you have to take care of the pain with non-opioids. With non-opioids medication, it is recommended that with non-opioids you have to first you have to go with the non-opioids and then opioids. It depends on the patient condition and the pain score. You have to assess the pain score, the facial rating pain score, and the verbal pain score, or the behavioral pain score. So there are different types of pain rating scores. So you have to assess it, and on that assessment, you have to give patient as a PRN drug or a continuous infusion. So in the opioids, we can prefer morphine or fentanyl, but morphine is not highly recommended as it causes delirium and it causes hypotension as well. So it is not really recommended, but fentanyl has a rapid more onset and it can be used as a continuous infusion. So yes, fentanyl is a choice of drug when you are thinking about opioids. For non-opioids like acetaminophen, NSAIDs, these are the choice of the drug, Epinephrine. So these are the choice of the drug for non-opioids, and you can choose among these drugs, but you have to consider the liver disorders when you are choosing non-opioids. It's like non-opioids are metabolized in liver, so when you are giving acetaminophen, so it can causes deranged LFTs, the patient who are having liver cirrhosis or INCAP. So non-opioids can really worsen those. So acetaminophen is not really for those patients. Next slide, please. We have a really good resource material with all the opioids and non-opioids classification and pharmacokinetics. So you can always refer that. So it's an adverse effect, as I have mentioned that with opioids, it's respiratory depression, hypertension, it decreases the GI motility, pruritus. It can cause, the opioids can cause the dependency in patient. So we have to be very cautious with the patient with alcoholism or substance abuse. Next slide, please. So here comes the paralytics. As discussed in the earlier slide, that by Shabana, that when you don't want patient ventilator height in layman language, and it is very much necessary for the patient, and it is very much obligatory when you use paralytics. So citalopram, acapulum, succinylcholine is choice of drug for paralytics. Succinylcholine is not used as a continuous infusion. It is a very short-acting drug. So citalopram and acapulum is a choice of drug. Paralytics paralyze the skeletal muscles and block the neuromuscular junction. So it helps to paralyze, completely block the skeletal muscles. But whenever you are giving paralytics agent to the patient, like Preceptor or Epinephrine, the patient needs to be completely sedate. Because when patient is not sedated and you are giving paralytics to the patient, now imagine what is going to happen. So the patient needs to be completely sedate. Sedation should be monitored when you are giving paralytics. With the paralytics, the side effects is like it increases the risk of deep vein thrombosis as the patient is not moving, the skeletal muscles are blocked and paralyzed. There are the risk of pressure ulcers and nerve compression syndrome. So as a nurse, we should consider positioning of the patient to reduce the risk, passive physiotherapy, DVT stockings. We need to cater those things, and we need to intervene with these interventions. Next slide. It's about the indication, like it is used for the intubation, like for rapid onset, we use succinylcholine for the intubation. When we are proning the patient in the sessions which are taken by Nasreen, she told you about prone position, so we can use paralytics when we are proning the patient for any procedure or any ventilator issues, like patient is not maintaining the ventilation and we don't want any patient ventilator fight or asynchrony, to monitor the effectiveness of paralytics. So there are many scales like 1 lead EEG, basic scale, TOF scale. Mostly we use trend of 4 scale. How do we use it? As you can see on the left hand side, there is a monitor. It talks about the TOF rating scale. So you can see the monitor. With the monitor, you can trigger the ulnar nerve, and you have to see the 4 major nerves, 4 major triggering nerves. And when you are seeing that with the monitor, a particular millivolts is given to the patient, and it triggers, the nerve is triggered, and the proper rating is there. So nurses are certified for it. Mostly in our settings, physician, pulmonologist, or certified anesthesiologists do this. So you need to be very much sure that when the paralytic agent is there, so the TOF monitoring is done by the physician or the anesthesiologist, or if the nurse is certified. The complication is that, like, it leads to myopathy, because when the muscles are not used, the skeletal muscles are not used for the prolonged period of time, it increases the risk of myopathy, increase the risk of weakness in the skeletal muscles. Delirium is also the main side effect. Diaphragmatic deconditioning, as a skeletal diaphragm is a skeletal muscle. So when diaphragm is not used for a prolonged period of time, yes, diaphragmatic deconditioning is there. With potassium level, with succinylcholine, you need to be really very careful with potassium level. As it increases the potassium level, it increases the risk of hyperkalemia in the patients. So you need to monitor the potassium levels. If the patient has hyperkalemia, so succinylcholine is not an option for paralytics for those patients. Next slide, please.
Okay, before we go to the question, I would like Dr. Jaffer to maybe summarize some of the stuff. There was a little bit of a problem with the audio throughout. So I just want to make sure, Dr. Jaffer, would you be able to do that? And then if I see Dr. Awais too. We have a few more extra minutes for the webinar.
Okay, so I think there was a lot of slides, and I know that there were some issues with the voice. So I'm going to summarize everything. So first thing is you have to have certain goals in mind. Okay, when you start a vasopressor, you want to make sure your patient is not hypovolemic. So the first thing is always first, hypotension must be treated with crystalloids. And if the patient does not respond to your crystalloids, then you go to a vasopressor. And for vasopressor, your goal is to have a mean arterial pressure, about 65 to 70 millimeter of mercury. You want to have a urine output, which is close to about 0.5 ml per kg per hour, which comes out to be between 30 to 40 ml per hour of urine output. You want to make sure that the patient's peripheries are perfused well. So that means that you can look at the toes and fingers. You want to make sure the perfusion is good. And other thing is for patients when to use inotropic agents like Dopamine and Milrinone. These are the patients who have poor cardiac output, and you're using your vasopressor. And with that, then you can add a inotropic agent so that you can help the cardiac output. I think I'm having some, somebody has their mic unmuted. Please mute your mic. Okay. And coming towards sedation and paralytics. So again, your goal is patient comfort. So if your patient is comfortable with your sedatives and is pain-free with your opioids, then you don't have to increase. You don't have to put a patient sleep. So your goal is patient comfort. So the patient should be comfort, be able to communicate with you, but should be less anxiety-free and also pain-free. Pain is always going to be there because of all the tubes and everything that the patients have. So most of these patients require some sort of pain medications, either a continuous infusion or maybe bolus doses of fentanyl or other agents. Dexmedetomidine we use sometimes because of, again, it does have some analgesic property as well as sedative property. But it is expensive, so you always want to look at your own institution if they can buy these medications. Otherwise, propofol, benzodiazepines, and also opioids like fentanyl, morphine. Again, they are all used all over the world for sedation and pain medication. Paralysis only needed when your patients need to be mechanically ventilated, especially those who need muscle relaxation to provide the mechanical ventilation. Very few patients need paralysis, and only for maybe 12 hours to 24, maybe maximum is 48 hours, so that you can help your patient. Otherwise, most of the patients do not need to be on paralysis. I think I will stop here.
We can go on to the question now, and let's see. Oh, good. We got a good message across, it looks like. So which of the following is true about paralytics? And no, they should never be started without sedatives, for sure. All right, let's go on. I think Shabana has a couple of points to make about nutrition. And then we will go ahead and summarize. Dr. Awais is here. If we have, we can certainly take more comments from him as well. Shabana, go ahead. Shabana?
Can you hear me?
Yes.
Okay, so for the nutrition slide, I'm just going to cover a little bit about it, that it's as we know, when Mrs. N came to our hospital, and then after going through a lot of stuff, and then finally she got intubated. So what we said that the tube feedings was not started. So according to the recent guidelines for the COVID patients especially, and even if patient is on ours, it's very important that we should start patients on the tube feedings if patient is on the ventilator. So it's the starting of nutrition on a COVID patient or any patient who has some pulmonary issues is absolutely the same as we start for any intubated patients. And the goal is to start within 24 to 36 hours of admission to the ICU, or within 12 hours of intubation if the patient is on mechanical ventilation. So if it's in your shift, patient got intubated, you have to make sure that you hand over to nurses. If there is no contraindication for patient, recommend that the tube feeding should start. And NG, most of the time the NG tube is placed when the patient gets intubated. So you have NG tube, all you have to do is to just go ahead and start. Usually the antral feeding, of course, is prioritized than the parenteral, because parenteral has lots of side effects. It has to go from the central venous catheters, and then it has more chances of developing more infection, and you have to take care of so many other other electrolytes and other things when you are administering a parenteral nutrients. So NG feeding is more preferable. It is also recommended that we should be giving in a continuous doses, continuous rate, not like a bolus, like just give like 250 cc in 2 hours, then another 250 in another 2 hours. So instead of giving bolus feeding, it's a best practice to do a trickle feeding, like little, maybe like 10, maybe like 15 cc's per hour, maybe like then start to 20, and you see if patient is tolerating, there is no issue, patient is hemodynamically stable, go ahead and start. Most of the time we make some goals that, okay, the goal for this patient as per the assessment done by the dietitian or the nutrition expert, they just give you a goal, okay, 50 cc's per hour should be the goal. So you just try to achieve that goal slowly to get the target. For most of the NG feeding, we also give some water flushes with that, just to flush out the tube, and it's not just get stagnant within the tube, because then it gives a lot of occlusions, and patient is, everything get occluded in the tubes, and also it's better to, and then we need some hydration for the patient as well more. So it's better to give some water flushes or some water feeding at the same time. So the nursing care for the patient, any patient who has any tube, is absolutely the same as you do for any with the tube feeding. And for the residual, this is always a controversy. I know the time I was the nurse, and we were always instructed to check the residual every 4 hours. If it's more than 100 cc's, just stop the feeding. I'm getting some noise behind. Someone has turned the mic on. So now the evidence says that we should not be checking the residual on the patient. Even if you are checking, and if the residual is 400 or 450, do not turn the nutrition. Let it go on its own pace, and we should not be turning off the nutrition at all. Now, for the situation when patient is getting prone, if maybe Mrs. N is recommended to be prone, then we have to make sure we have to empty the stomach content before we are proning. But while the patient is in prone position, you still can go ahead and continue the feeding. And for that, we have to check all the rest of the nursing care is absolutely same, to check the skin, to check the if there is no occlusion, change the tubings every 24 hours, make sure the feeding is not in the feeding bottle or feeding bag for more than 24 hours, change the bag. Those basic nursing things are very, very important when you are administering nutrition. I think with that, we end up our presentation, and we really apologize for all the technical issues that we encountered today that all were not anticipated. But if you have any questions, I'm not sure if we have time and we can allow open floor for questions. But if you have any concern, anything that we can take care of or answer, please put this on our question and answer session, and we'll be more than happy to give you a little recap on the medications. And we'll be putting some very important resource material on our website that has the dilution, that has the start dose and the max dose of all those important medications, and how they are made for the pediatrics as well as the adult. So it's going to give you pretty good information about it. And if there is any other thing that we can help you out for any information, please feel free to put that on our question and answer or comment session. Thank you so much.
Thank you, Shabana. And Dr. West, do you have any comments?
Yes, a brief one. First of all, it was a great session. Actually, I learned a lot of things, and particularly from nursing aspects, which I didn't know, so I learned, and it was a great presentation today. So other thing I would like to add about inotropes, which we use when patient is hypotension. So inotropes, mainly we use two, which is Dopamine and Midrinone. So in patient when have hypotension or septic shock, at that time, if need inotropes, I think Dopamine is used more because it's short acting And Milrinone actually is used more often in a chronic basis for a long period of time. But we have to be careful about Milrinone in case because it's excreted by kidneys. And very, very commonly, I see that a dose is given is too high. If renal function is not optimum, you need to adjust the dose, and it causes very commonly hypotension, and that can lead to complication. So I always talk to cardiologists, and I'll adjust the dose myself because they sometimes forget. They think that that's their medication and they have to adjust, but they always end up giving too much of a dose of Milrinone. So just important comment on that.
Thank you, Dr. Awais. I think we are coming to the close of our session. We will see you next week, and please put your Q&As in. We will address them at the next session. I also want to remind everyone that there is a feedback form that needs to be filled out, and please do that. And we do have an MCQ session on September the 12th. That is the last session of these webinars, where we will have opportunity to answer many of the questions that you might have. We'll go over all the questions that are already in the bank, and if there are any more that you are sending, we will try and address that in that 1-hour session on September the 12th as well. Thank you very much, and I will take your leave now. Thanks a lot for attending.